live question and answer session for hyperparathyroidism, mostly primary hyperparathyroidism. But I thought today we would start by looking at actually secondary hyperparathyroidism for just a minute, just so that I can explain. So when you look at this diagram here, it shows you how the parathyroid system works. Okay, so you have the 4 parathyroid glands hiding somewhere close or behind the thyroid. And all they're doing is looking at the level of calcium in your bloodstream, right? Red calcium in the blood. Now, 98% of the calcium in your body is in your bones. 1% is in the blood. 1% is in tissue, muscles, skin, nerves, so on and so forth, right? Your parathyroids are only looking at the calcium that's in your bloodstream. They don't care about the calcium in your bones. They don't care about the calcium in your tissue. They only care about the calcium in your bloodstream. So when the calcium level in your bloodstream goes down, they produce parathyroid hormone, which goes to your bones and tells your bones release calcium in the blood. That's how it brings the calcium back up. Parathyroid hormone goes to your kidney, tells your kidney, don't let go of calcium so easily, resorb it back into the bloodstream. We need more calcium in the blood. In the kidney, it activates an enzyme called 1-alpha hydroxylase, which transforms inactive vitamin D, or calcidiol, the vitamin D3, 25-hydroxy vitamin D3, the one that's tested on blood tests. That's an inactive vitamin, right? And this enzyme, with the help of PTH, changes the inactive vitamin D to active vitamin D, called calcitriol, or 125 dihydroxy vitamin D3. This active vitamin D goes back to the kidney. Most importantly, it goes into your intestines and increases the absorption of calcium from 20% to 80%. So without vitamin D, activated vitamin D, you're not absorbing a lot of calcium from your food. It also goes back to the parathyroid glands and decreases PTH production and decreases growth of parathyroid glands. It prevents the parathyroid glands from growth. So these feedback loops are working all the time. Now, what is one of the most well-known causes of secondary hyperparathyroidism? Kidney failure. So when your kidney fails, right, you no longer have this enzyme to activate vitamin D. So you don't have this. So the absorption of calcium stays at 20%. So no matter how much calcium you eat, you only get to absorb 20% of that. Okay? So your calcium levels drop in the bloodstream. Okay? It also doesn't suppress PTH. So your PTH numbers go up, and it doesn't stop the growth of the parathyroid glands. So the parathyroid glands over time grow to be bigger and bigger and bigger, right? And they just keep producing more and more PTH. So that's one way of getting secondary hyperparathyroidism. It's basically having your kidney not function. People who are on dialysis have kidney failure, right? And so that's one of the most well-known causes. Very hard problem to deal with, because now you have kidney issues and all the secondary consequences of kidney failure, right? But there are other causes of secondary hyperparathyroidism, okay? And so vitamin D deficiency, okay? So just like when kidney failure decreases vitamin D activation, if you don't have enough vitamin D3, 25-hydroxy vitamin D3 in your system, then you're not going to absorb calcium as much. So treatment is vitamin D supplementation. Low calcium intake. If your diet just doesn't have enough calcium, if you don't eat a lot of green leafy vegetables, you're an absolute carnivore. You're not having almonds, dairy products, and so on, you may not have enough calcium in your system, and you'll have low serum calcium and 24-hour urine calcium, which can easily be treated with supplementation. Low magnesium can cause uh, your PTH to rise up. Okay, there's this condition called renal calcium leak, where the kidney's just leaking out calcium. It's a genetic condition. Usually, these patients have a lot of kidney stones, but what they have is a lot of calcium in the urine, and it's treated with a medication, hydrochlorothiazide. We talked about this, kidney function, malabsorption. So if you have true gluten intolerance, which is an autoimmune disease, when you have gluten, it attacks your um, intestines, inflames your intestines, and you can't absorb it. This is a blood test for it, and then you can treat that. And these medications, right? These medications can also cause your PTH levels to falsely elevate, right? And it's easy to treat. You stop the medication and you check lab. And so these are the secondary causes. Now, there's also this condition that can occur to us as we age, where our intestines become resistant to vitamin D, 125 hydroxy. So you need higher levels of that to perform the function of absorbing calcium, right? And so that is a consideration in the elderly population if you have a patient who has normal calcium levels and elevated PTH. So secondary hyperparathyroidism means something's causing your calcium levels, I'm sorry, your PTH levels to go up. In the case of kidney failure, you can have really high calcium numbers also because of the kidney malfunction and filtration issues and so on. In the case of vitamin D deficiency, you generally don't have elevation in calcium. You have normal calcium level or low calcium intake or low magnesium or malabsorption. You have normal calcium levels and elevated PTH, and that's driving the whole system and making it look like you have secondary hyperparathyroidism. Most of the secondary reasons are very correctable, right? So that these are questions and comments that come up a lot, and I think knowing what the story is and how it comes about really can help. Um, really can help you uh, figure out where to go with it because it's such an unknown. All right, so let's start with our first question, which is from Suzanne Reese. Prior to surgery, would a doctor have the patient stop taking calcium and vitamin D3 so they can get accurate measurements before and during surgery? Not necessarily. Okay. The reason for it is the half-life of parathyroid hormone is 4 minutes roughly, right? 4.5 minutes. Okay. So when you have a parathyroid tumor, so let's say you have this parathyroid gland that's turned into a tumor and it's producing a massive amount of PTH, right? A lot of PTH. Whatever PTH this is producing, right? At this moment in time, so to right now, right before I remove it, let's say it's producing 120 units of PTH, right? And the normal parathyroids that are not working are shriveling up and getting smaller, right? So they're smaller now, okay? And producing very little PTH. So whatever amount of PTH this is producing, when I take this one out, this abnormal parathyroid out, the number of PTH should go down by more than 50% within 10 minutes, right? So within a half-life, you have a little bit of PTH being produced by the smaller glands, right? So it won't be exactly at 4 minutes or 5 minutes, it'd be a little bit longer, but it should go down. And so having extra calcium in your system is not going to affect the half-life of PTH. having extra vitamin D, it may make your original number be a little bit smaller. Maybe instead of 120, you may have 100, but you still have to go down by more than 50% into the normal range to have that. So I don't necessarily have people stop calcium. I don't necessarily give people calcium supplementation before surgery either, right? I do give patients vitamin D supplementation and just 2,000 units daily. I don't go to exorbitant amounts unless I suspect that they have secondary hyperparathyroidism due to vitamin D deficiency. If I've if I've already figured out that that's not their problem, that they have primary hyperparathyroidism, and uh, I'm just giving the vitamin D to protect their bones essentially preoperatively, then I don't feel the need to take them off of that. I don't think it affects things. Now, if you have borderline numbers, right? So if your calcium, let's say, is 10.3, just above the normal, and your PTH is 67, just above the normal level, right? Vitamin D and calcium supplementation can reduce this number to, let's say, take it to 60 instead of 67. But during surgery, I'm still looking for a 50% reduction. Now, in someone who has borderline numbers, I may take him off the vitamin D supplementation and calcium just so I can get an accurate, just so I can see the measurement changes more so, right? Because there's not as much PTH around in this scenario, okay? But I don't think it's necessary when you have really higher numbers. Now, in your question, uh, you wrote calcitrol. That I mean, I thought that was calcium, but maybe you're trying to say calcitriol. Calcitriol, I would have the patient come off calcitriol because calcitriol really decreases PTH very avidly. Okay, so hopefully Suzanne, that helps. Um, Lisa Renee, 3 years post-op, have one remaining parathyroid gland. Serum calcium is 8.6, PTH is 12, ionized calcium normal. Your thoughts? My thoughts. I, Lisa, I really actually prefer that you ask me a direct question rather than my thought on a few numbers. Um, on the surface, if that's what you're asking me, 8.6 and 12 seem like low calcium and PTH numbers, but those are all almost irrelevant if you're not having hypocalcemia symptoms. So if you if you if you're not having numbness and tingling in both fingertips or around your lips, if you're feeling fine, energy level is good, you're active, everything's feeling fine, then calcium of 8.6 is probably what your body likes, right? But if you're having symptoms, then my thought is you're not producing enough PTH to adequately service your body's needs, and you're not absorbing enough calcium from your food, and therefore you need probably either calcium and vitamin D supplementation or injections of PTH. If your vitamin D is low, which you just stated, then I think vitamin D supplementation is very, very crucial trying to help you. But it really has to do with how you're feeling. Okay. Linda Groff Williams. I'm 70 years old and afraid of surgery. Although I would probably be considered healthy enough for surgery, would it be okay to opt out of surgery and stay on medication for hyperparathyroidism? I've been diagnosed for the duration. So you're talking about being on cinecalcet to manage illness. Um, so let me explain. Yes, you can, right? Um, yes, you can. But I would say if your bone density is low, I would suggest that you do surgery. So let me explain why. During the normal course of a day, right, at 6 a.m., you have a surge in PTH. And again at 10 a.m. and sometime in the afternoon. The rest of the day, your PTH is low or not peaking out in a normal parathyroid. Why does that happen? When you have these peaks and you have high PTH, the PTH goes to your bones and activates a set of cells called osteoclasts. And osteoclasts eat your bone and release calcium into the bloodstream. So during these brief blips and elevations in PTH, you have your bones being eaten, while the remaining time of the day, the blue areas, osteoblasts, which make bone, are redefining your bones. So your bone is getting rebuilt the rest of the day, right? This process is what allows you to have healthy bone and a regeneration of bone. That's why every 11 years, your skeleton is completely replaced by new bone, because on a daily basis, you're recycling bone and redoing its architecture and making it strong, right? It's a fantastic system. If you have an enlarged parathyroid that's producing a lot of PTH and you're constantly up here, you don't have a chance to rebuild your bone, which is why you get osteoporosis. You have leaking of bone and no rebuilding of bone. Now, if you take cinacalcet and you bring your PTH level down, right, and now you're here, you still don't have these periods where you get ups and then downs to rebuild your bone. So in your particular case, I would say check your bone density. If your bone density is healthy and you're feeling well, then you can try the cinacalcet. And if you try the cinacalcet and you feel even better, fantastic, continue, right? But if your bone density is not healthy, I don't think cinacalcet is the right choice. I don't think that's going to allow you to have improvement in your bone. It may slow down the bone loss, but I don't think it'll allow you to improve. Okay, so that's my thought on that. All right, Monty Stopia. After having successful surgery for normal calcemic hyperparathyroidism with hyperplasia, my pathologic report came back and showed 3 glands removed at 150 milligrams, 60, and 40, all of which were considered normal cellular. As I understand it, typically hyperplasia glands come back as hypercellular. Is there any understanding as to why hyperplasia glands might be normal cellular versus hypercellular? For instance, if the hyperplasia is a result of tertiary hyperparathyroidism, might it be more likely to be normal cellular, whereas if it's genetic, then again, would it be hypercellular? Um, I see. So let me explain. It's all the stage at which you catch this disease, right? So normal parathyroid glands are what we call normal cellular, is this microscopic slide where the parathyroid cells, this is a clump of parathyroid cells, right? And every little dot in there is the nucleus of a parathyroid cell. And you can see hundreds in this little clump. In between them are fat cells, right? All of these are fat cells. So a normal parathyroid gland has 50% parathyroid cells and roughly 50% fat cells. Roughly, and everybody's a little bit different. As you become abnormal, you have more parathyroid cells and less fat cells, okay? So, and the more abnormal you become, the more PTH you're producing. The more parathyroid cells, the more PTH you're producing. Okay? So, if you have hyperparathyroidism and your PTH numbers are not very high, so range of normal for PTH in the US is 15 to 65 roughly. So if you have normal calcemic hyperparathyroidism and the range of normal for calcium is 8.8 to 10.2. So if you have hyperparathyroidism and your calcium is 9.8 and your PTH is 70, this is a normal calcemic hyperparathyroid patient. 70 being just slightly above normal means that this parathyroid that's abnormal, or all of the parathyroid, you have the hyperplasia parathyroids, all of them are only producing a slight increase in PTH, which means they really didn't have to go from 50%, 50-50 to this scenario, which looks like 90-10, right? So it could be that your particular 4 parathyroid glands, instead of being 50-50, are now 57-43, which under the microscope to the eyes of a pathologist may look normal cellular, right? So that's the reasoning why at a lower PTH number, when you have hyperplasia, your pathologist isn't going to tell you that you have abnormal looking glands because the cells look the same in both scenarios. It's just the proportion of fat to cell. So because your PTH number is not immensely high, you're gonna have very normal cellular looking parathyroid glands under the microscope. People who have MEN generally are born with hyperplasia, and by the time it's discovered, usually um, the PTH number is very high, and so they've grown a lot, so they appear very hypercellular under the microscope. That's the reason why. It's not the normal calcemic versus. It's how much PTH is being produced. It's just that. It's just that generally speaking, for people who don't have MEN syndromes or don't have kidney failure causing hyperplasia, their hyperplasia is slow growing, and so they generally are not very hypercellular because their PTH numbers, excuse me, are not very high. It is really rare for me to see someone who has a PTH over 100 that has hyperplasia, that doesn't have kidney failure, right? So in general, majority of hyperplasia patients that I get to operate on are normal cellular when I look at it under the microscope. It adds a challenge, but it is the way it presents itself. Very interesting question. Shona Jean. Thank you for the opportunity, Dr. Larian. My pleasure. Shona, I would like to know a ballpark percentage figure of recurring kidney stones after parathyroid surgery, please. At a large grape size when blasted in April 2019 and feeling similar pains to when it happened. Shona, so when you have hyperparathyroidism and you get kidney stones, that's because in the kidney itself, you have little so in the kidney, you get little points of stones, right? That's during the time you have hyperparathyroidism, let's say with an adenoma, okay? When you get rid of this thing, those stones don't all of a sudden disappear, right? You're still filtering calcium out of your kidney, and if you already have tiny little stones, and they may be microscopic and not visible on any scans, but they will still get more calcium deposits attached to them, right? There are reports that state that it takes usually 10 years before new stone formations stop and before stone formations diminish. In the immediate future after surgery, the chance of needing to go to the emergency room for bigger stones becomes less, right? The frequency of visits to the emergency room may become less. right? But you still have stones, and it takes years and years and years to get rid of them completely. Generally speaking, about a decade. So I can't tell you a percentage per year, but generally speaking, it really, the percentage has to do with how many stones you have at the beginning and how efficient your kidney is. If you, there are people who have kidney stones without hyperparathyroidism. So if you have a genetic predisposition to getting kidney stones and you have hyperparathyroidism, obviously you'll have a lot more stones and so on. So it's a complex subject, but it literally takes 10 years before you're finally rid of this thing. Good luck, Sean. Susan Stein. I'm in my 70s. If I've never had kidney stones that I know of, how likely is it is that I could get stones from it taking a very high amount of calcium post-op? Uh, I've never seen it. It's possible, but I've never seen it. I am pre-op. How can you tell if pain after surgery is from cutting out parathyroid glands and manipulation of thyroid or from being intubated? Your parathyroid glands don't have any nerves going to them. Your thyroid has some nerves around it. Okay, so if you have Hashimoto's thyroiditis and you do surgery, you can have a little bit more inflammation in the thyroid and feel it. But majority of times, when people have an intubation and have parathyroid surgery, in my experience, it's the intubation, the sore throat from the breathing tube, which lasts 3 to 4 days. What they complain about, which is generally why I try to do these surgeries without intubating under local anesthesia. Easier recovery, less sore throats, and so on. All right, Stephanie Smith. Hi, Dr. Larian, me again. Hi, Stephanie. This time asking for my husband. His calcium is consistently in the 10s. Last time was 10.7 with the PTH of 25. History of bilateral kidney stones. All other tests are normal. And ultrasound showed an adenoma almost instantly. How can this be when his PTH seems normal? What would be the successful surgery if the PTH can't drop much more? So, your husband has normal hormonal hyperparathyroidism. Eric Matthew responded um, that he had normal hormonal hyperparathyroidism with a calcium of 10.4, PTH 31, and after surgery his PTH hovered around 9. So normal hormonal patients, people, this is an example of one, right, where calcium is elevated, but the PTH is in the normal range, right? So what you have to do, Stephanie, or what your husband has to do is rule out all the other causes of calcium elevation, right? And this is it. He's number one is hyperparathyroidism, but you and your husband have to look at all these other potential causes. And you may want to take a picture of this, or you can look on my website for this diagram and discuss it with his primary doctor to rule out all these other potentials. Look at medications and make sure he's not on any of these. Of course, look at kidney function. This is TPN is total IV nutrition, someone who doesn't have intestines or has intestinal issues and can't absorb. May go on that. And just basically a workup of all these other conditions, right? Which is not difficult to do. If all of this proves negative, right, then your husband has primary hyperparathyroidism called normal hormonal hyperparathyroidism. These patients are thought to be very sensitive to PTH. So for them, they start at a normal and then surgery's done, just like Eric had said, their PTH numbers hover in a lower range, right? These patients are sensitive to PTH and don't need as much. So their range of normal, instead of 15 to 65, maybe 5 to 20. And a PTH of 30 will be very high for this person, okay? So please have your husband do a full workup. Good luck, my dear. And then Stephanie asks, Eric, thank you for sharing. How are you feeling? How did surgery go? Response from Eric, Stephanie Smith, I feel great. Great. Thanks for sharing, Eric. Constanza Resende Adam. Hi, Constanza. Buenos dias, doctor. Oh, oh, Spanish. All right. I had an operation in 2013 for primary hyperparathyroidism and kidney stones, bilateral kidney stones. I had kidney stone surgery in 2018. My Spanish is better than I thought. 2020, 2024, I have 6 episodes of urinary tract infection. Okay, so your doctor is telling you that you're wondering if these episodes are related to the hyperparathyroidism. Well, again, it takes 10 years, but you've passed the 10 years at 20, since you had your surgery in 2013, 10 years roughly. So in 2024, at 11 years, you still have kidney stones, which may have caused urinary tract infection. What I really think you need to do is do an ultrasound of your kidneys, see if there's any more stones first, just to get that fact. If there are stones still, you may want to look at your calcium, PTH, and vitamin D to see if you have a recurrence of hyperparathyroidism, right? In which case it would explain why you're having the symptoms that you do in the kidney stones persistently, okay? Good luck, my dear. Janice Tucker Rhoda. How long before most patients get their voices back after parathyroidectomy? Well, Janice, it all depends. It all depends on what the cause of your voice loss is. Let me show you something funky. Okay. So when you look at the throat, this line here is the vocal cord sitting on top of the breathing tube. And behind it is the esophagus that goes to your stomach. Okay. So the view up top, if you're looking down at the voice box from above, these are the vocal cords. And when you speak, normally they come. And when you breathe, they come apart. So air can go in. Okay. When you're having intubation, you're basically putting a breathing tube that goes in here that can get the air through it into your lungs. Okay. So if your anesthesiologist uses a larger tube, that larger tube can irritate the vocal cords. If that is what's happening, then it all depends on how much irritation you have. So if the irritation is minimal, 2-3 days later, the voice should be back to normal. If your voice box is very irritated, right, and everything is red and swollen, it may take a couple weeks for it to get there. If you have acid reflux from hyperparathyroidism and you get swelling of the vocal cords, right? And then on top of it, you have a breathing tube that goes in there that really causes everything. It may take a month and a half of treatment with acid medications to get you to that, right? If your surgeon during surgery caused a paralysis of your vocal cord, which may be temporary or permanent, if it's temporary, it depends on how long it takes, and it can take months for the paralysis resolves, right? If it's permanent, then what you may need is an injection of some material here, the stuff that we put in the lines in the face that cosmetic surgeons do, to fatten up your vocal cord and bring it to the middle so that the other vocal cord can meet it. So all of these possibilities exist. I suggest that if you're having trouble with your voice, to visit an ear, nose, and throat doctor and have them use a camera through, to look at your voice box and see what the reason for your problem is. So that way they can tell you exactly what's going on and how they can help you, right? The chance of vocal cord nerve injury is very low in parathyroid surgery. It's less than 1%. It should be less than 1%. Um, and so hopefully and most likely it is not that. It's probably irritation from the tube. All right, good luck, Janice. Dear Dr. Larian, some doctors recommend calcium carbonate, with others recommend calcium citrate. Which do you recommend and why? How much do you recommend taking before and after parathyroidectomy? Okay, Janice again. All right, good question. I actually, this is what I do. You're gonna see my secret. I use Citracal, which is calcium citrate. Why the Citracal? Um, the reason I use Citracal is I found that Citracal is less upsetting to the stomach, at least in the after surgery time period. So that's why I use it. Um, in terms of long-term use of calcium, um, I prefer that you get calcium from natural sources. So green leafy vegetables, almonds, dairy products, and so on. I try to not have people be on calcium supplementation. But if they do need to take it, there's so many different forms. There's oyster shell. There's so many different forms, you know. And I would suggest if you're taking calcium in the long term, to try different forms and see which one agrees with your system the most. Okay. Lina Manuha. After the surgical removal of one of the parathyroid glands, can the tumor regrow again as the P tissue is increasing gradually post-surgery? Unfortunately, yes. There's anywhere between 3 to 10% lifetime chance of getting another tumor in another parathyroid gland. And so that's why with every person that I have has surgery with me, I urge them to do calcium PTH vitamin D checks annually, just to make sure they can they can they can see what's going on, and if hyperparathyroidism coming back, we can catch it at an earlier stage. What if you only have one parathyroid gland left due to complete thyroidectomy and it is suspicious for a tumor? Oof. Then then you're in trouble. Then you need an expert parathyroid surgeon. Okay? So, you have hyperparathyroidism for an adenoma. That means that means one cell in a parathyroid gland became abnormal, one cell became two, two became four, and it started growing. But you still have a rim of normal parathyroid at the edge of it. And so that's what it looks like here. So this is the cell that got the mutation, became abnormal, and it started growing and growing until it became this tumor. And the normal parathyroids that were around it shriveled up and became a tiny little rim at the edge. If in your scenario, I'm doing your surgery and I find this normal parathyroid on the edge, right? I would do a tiny biopsy of it and compare it with this. And if that proves to be parathyroid tissue, then I would take it, cut it into little pieces, and implant it in the muscle, either in your neck, chest, or your arm. I usually just use the neck because it's right there. And in the hopes that blood vessels grow into it, into all the little pieces, and it'll start to function. There's an 80% chance that that'll work. Now, you don't always find that. You don't always, not all parathyroids are like that. So let me show you. Let me show you some examples of other parathyroids. So here and here, you're seeing a little bit of normal. In this one, I don't see a normal at all. In this one, I'm not seeing a normal, which, so it could be that this normal is in the middle of it, inside the parathyroid, the normal part, and the parathyroid is engulfing it. Usually it ends up being at the edge. So if you look carefully enough, you probably will find it. That would be my suggestion. If your surgeon cannot find it, then what they have to do is when they take out this parathyroid, they take a small portion and they cut that small portion and put that in the muscle of your neck, and then monitor the functionality of it. Mark that area of the muscle so if it ever misbehaves, you know where it is to remove it. Good question. Good luck. Okay, next question. I had one parathyroid removed last year and my calcium is balanced. I noticed that certain medications affect my electrolytes as I am sensitive to changes. For example, my doctor switched my blood pressure medication to a calcium channel blocker and it caused me to have severe jitters. Then I switched back to losartan potassium and I get muscle cramp. Do I have to take Tums during this transition? Will I always be sensitive to minerals now? And if so, what type of medications and supplements should I avoid? Um, Very good question. Impossible to answer. I know the fact that you switched to a calcium channel blocker makes you feel like it's the calcium issues that are contributing to this, but it's not. It's actually your particular sensitivity, right, to the medications that are causing it. It's not the fact that you had hyperparathyroidism in the past that's doing this. Um, I don't know if there's a general statement about sensitivity that I can make to help you out. Unfortunately, you may have to try things out to figure that out because everybody's sensitivity is different. Right. Next question. I'm 65-year-old. I'm a 65-year-old woman who had hyperplasia surgery 2 years ago. Although I had hyperparathyroidism for over 15 years, it took a compression fracture in my back from coughing to get the job done, unfortunately. My question is, if the partial little bit of diseased tissue left behind doesn't last me the rest of my life, can surgery be done again to cut it down to a smaller portion? Yes. So the way I like to do this surgery, hyperplasia surgery, is to essentially do this. So I like to find all four parathyroids, of course, right? But I like to preserve the blood vessel going into that small parathyroid and coming out of it. Usually they come from the same end of the parathyroid. And then if I reduce the size of that particular parathyroid, I do it and pull away from the blood vessels so that the blood vessels are maintained. And I usually put a little titanium clip there to show me the end that's away from the blood vessels. So that if years from now, this parathyroid gland grows and grows and grows and grows, I have a clip at the end away from the blood vessels, right? And I can go in there and now cut this parathyroid down and check PTH numbers to make sure what I've left behind is not overworking, but working adequately. So it can be done, especially by your first surgeon if they have had a lot of expertise doing this. I essentially, after hyperplasia surgery, do this diagram. I show where are the parathyroids that I removed, and then I draw exactly where is the parathyroid that I left behind, on frontal view and side view, so that if I have to go in there, and then what the relationship is to the vocal cord nerve, so that if I have to go in there, I know exactly where that parathyroid is, and it helps me get to it easier, faster, with less problems, and potentially be able to do the surgery and preserve your parathyroid. Very good thinking. That's exactly the way it should be done. All right. Look. One more question, if I may. If the last piece of parathyroid goes bad, will the same symptoms that I had before return? As the PTH number goes up, symptoms show up, but to different degrees. So it may not be exactly the same sequence of symptoms, but most likely it will be. The person gets used to suffering over the years and keeps on keeping on with life. Yes, and especially women. And because this disease is happening in women more, you guys are designed to be more tolerant. You give birth. A human being comes out of a small opening and you guys champion through it. Imagine me or many other guys that you know trying to do that. So you're designed to put up with stuff, right? You're designed to be tolerant. And that works against you in this scenario, unfortunately, because you put up with it. You rationalize it, you excuse it. You go through so much change every month as you cycling through your life and your menstrual cycle, that you are designed to tolerate changes. And so you tolerate this kind of a change, unfortunately. And so, yes, you are absolutely correct, that you keep on keeping on. And then she goes on to say, you just don't know how you were supposed to be feeling all the time till you have surgery. Thank you again, Dr. Larian. Much respect to you. They found one of the glands on my thymus with a gland function in that location, or just sit there. It would function just fine in that location. Your parathyroid gland can function anywhere. I've taken parathyroid glands over the heart. It's functioning normally. Well, this one was abnormal, but it can function normally anywhere it is. I've taken parathyroid glands in the throat all the way up just deep to the jaw, right? So parathyroid glands can function anywhere as long as the blood is going into it and one coming out. That's all it requires. Hello, sir. My name is Kuldeep Gupta. I am 33 years old. I had parathyroid adenoma before 5 years, and after surgery of 5 years again, my PTH is high, very low bone mineral density, but my calcium, vitamin D are normal. What should I do right now? Please help me. Well, you probably have normal calcemic hyperparathyroidism, right? And a normal calcemic hyperparathyroid situation, let me show you a scenario. This one, this one, that one, this. Okay, so calcium is normal, PTH is elevated. So in this scenario, you have to figure out why your PTH is elevated and rule out all the other causes. These are other causes of PTH elevation, right? So you have to look at vitamin D deficiency, low calcium intake with 24-hour calcium measurements, and blood calcium, low magnesium, potentially check your magnesium level, malabsorption problems that may have developed, medications, kidney malfunction, and so on. If you've looked at all of these and either corrected them and you still have an elevated PTH, then you have normal calcemic hyperparathyroidism and will need to do surgery to treat that. Good luck, Kuldeep. All right, that's the end of the questions that were sent before. Let me look at the set of questions that have come in during the conversation. Egon Murphy. Hi, Dr. Larian. I'm worried that all my adenomas may not be found during surgery. I'm a normal calcemic, but my PTH is consistently very high. At a 40 CT scan, which found an adenoma. Then I had an ultrasound which found a different adenoma. My endocrinologist has sent me for a system scan. I'm waiting the results. Again, the most important thing you do now is find a surgeon that has a lot of expertise in parathyroid surgery, not thyroid surgery, parathyroid surgery, that they do a lot of it, 50 or more a year. And they can take an interest. They do PTH testing during your surgery. If you have parathyroid tumors on both sides, you probably will need to use a breathing tube and intubation, which could monitor your nerves in that setting, so it can make the surgery safer, right? The most important thing, again, is find an expert surgeon to help you out with this. Okay. Burak Arpachi. Hi, Dr. Larian. Where was the most surprising location in your experience that you found an ectopic parathyroid adenoma? I'll show you. There's a little bit of video. So this is a patient who had a parathyroid adenoma. Oh, sorry. Deep to the jawbone. This is too big. The parathyroid tumor was much smaller. It was this big and here. Okay. Let me show you. So this is the MRI of this person. On the MRI, you can see the ear here on both sides. So size of the neck there. The thyroid gland is all the way down here. These are the jaw bones on each side, okay? And the parathyroid, as you can see, was just deep to the jawbone there, okay? And this is the surgery going through the neck, following the carotid artery all the way up there. And that's the parathyroid. This, okay, let me take you to the next one. So this here is the parathyroid tumor, adenoma. This item which was pulsating is the carotid artery, and this thing that you see here is the nerve that goes to the tongue. Comes out of the brain, goes to the tongue. The parathyroid was hiding in the capsule of this nerve, so I had to open the capsule of the nerve. You can see the nerve here is covered by a capsule, and here it's uncovered, and the parathyroid tumor is now removed. So that's probably the most surprising place for me. Do you need to take D3 or would it be okay to take D2? D2 is transformed into D3, so you can take D2. I prefer D3, but I think that's okay. Emma Hasley, is it normal to experience thirst and bone pain after surgery? How long does this normally last? As you're healing from hyperparathyroidism, let me come out of this picture. As you're coming out of surgery and you're healing from parathyroid surgery, your calcium levels and PTH levels have come down, but your healing is not in a straight line. It's 2 steps forward, 1 step back. It's a little bit of a jagged recovery. And during those times where things are going up and down, and calcium and PTH are going up and down, and all the organ systems are working to try to figure out how things are, and your bones are trying to grab calcium, you may have some of these symptoms. And it's hard to know how long it's going to last, right? It really depends on how long you were in the hyperparathyroid stage. The longer you were in it, the more protracted the recovery will be. Janice Takaroda. Dear Dr. Larian, some doctors recommend calcium. Yeah, already asked that. Janice got that one too. Robin Provost. My odd question. How long after parathyroid surgery can you get a neck lift? I would wait 6 months. Just let everything heal, because you want you want to have the scarring from your parathyroid surgery be mature and not changing, so that when you do a neck lift, you don't want to have a target, a part of your neck that is continuing to scar up more, right? So I would wait 6 months minimum. Kathleen Perry Ortiz, what is easiest calcium to take for a sensitive stomach? I use Citracal, and they're not easy. Some people find Oscal easier. There is one company that makes sublingual calcium. That may be easier, so it doesn't affect your stomach. Um, I haven't found any. Um, and then Kathleen asked about berry melts or bariatric chews. Those are good too. Um, you just have to test things out and see what works for your stomach. Everybody's very different, unfortunately. Excuse me, Libby Holland Ross. I was just diagnosed with parathyroid adenoma, and the endocrinologist is not recommending surgery. It is a 14 by 9 millimeter and was picked up on sestamivi scan. I have hypercalcemia for the last 4 years, and the first scan showed nothing. My calcium has been coming back on the high end of normal and slightly over with PTH within normal range. I noticed that the PTH was not on the low end considering how high the calcium is, so I requested a new scan. The argument is that I have not had any kidney stones and PTH is not elevated. Also, calcium has not been overloaded, so she's not recommending surgery. What should I do? Lily, this is what I suggest. Look at the symptoms of hyperparathyroidism. This is the list. If you're not having any of these symptoms to a degree that affects the quality of your life, right? If you're not having any of these, if you're energetic and healthy and active, and your kidneys have been looked at, there's no kidney stones, and you've done a bone density and you have no bone loss, and if you're over the age of 50 and you're doing phenomenally well, you may not need surgery, okay? Because this is not affecting you much. I would regularly check your calcium, PTH, vitamin D. I would annually check your, or at least at a minimum every other year, check your bone density, check your kidney for stones, and check your kidney function yearly. If all those things are staying steady, you have the potential of not doing surgery, okay? And monitoring it. But if you're having symptoms on this list that are affecting the quality of your life or bone loss, then I would definitely suggest that you do surgery. Or if you're younger, if you're young, not only young at heart, but physically and health-wise young, right? If you're 65, healthy and active, and you're going and hiking Kilimanjaro and having a blast in your life, treat your hyperparathyroidism so you can have a very good quality of life for what remains of your beautiful life. Okay, that's my suggestion. The Hawkins, I'm trying to determine if I have normal calcium hyperparathyroidism or secondary. When I first found this, my calcium was 9.0, my vitamin D 35, PTH 125. After 9 months of calcium, it is not it is not 9.6. It is now 9.6. Vitamin D is 60, and PTH 80. So um, you have normal calcium hyperparathyroidism. Um, at this point, again, you want to look at the chart of what else causes elevations in PTH, right? Which is this chart. And if none of these other things exist, then you have normal calcium hyperparathyroidism, and you should have it treated. Robin Provost, if you are in need of a second surgery, you were diagnosed with hyperplasia from your first surgery, two were removed, although pathology said one was a lymph node. Now they're saying that the bottom left has an adenoma which was never picked up, and it's like an iceberg, with the gland looking normal, and the adenoma is hiding below it. Also, fourth gland could not be found. What would be your course of action? Would you remove the one that has the adenoma and auto-transplant a piece of it in? I would check PTH levels. So, you had a surgery where two parathyroids were removed. And then on final, you found out, no, one of those parathyroid was a lymph node. So you've only had one parathyroid. So presumably you have three parathyroid glands left inside. How well they're functioning, are all of them alive and survived your first surgery? I don't know. I don't know what the extent of your surgery was during your first surgery. So what I would do is go in and remove that adenoma, right? Keep it in saline, cold saline, and check PTH levels. If your PTH that you start off with is, let's say, so this is the scenario, right? You had surgery and this one was removed. And then they removed a lymph node, right? So you have three more left. You don't know if they're all alive. But on the scan, you found this one as being large. I would go in there, check your PTH. Let's say your PTH is 70, right? After taking this out, I would check your PTH again. If the PTH at 5 minutes is 30, at 10 minutes is 26, and 15 minutes is 21, which means the PTH came down and plateaued, that means there are other glands alive that are producing PTH 1 or 2, and they're working normally, surgery is successful and done. If, on the other hand, you check it and your PTH goes from 70 to 3 at 5 minutes, 1 at 10 minutes, and 0 are undetectable, then you know the other ones did not survive. That's when you take a portion of the parathyroid that you took out, cut it into little pieces, and insert it in the muscle, either the neck, chest, or forearm. Rachel Kinney, how many milligram calcium do you need post-op long term? It all depends on your bone loss. If you don't have osteoporosis, then you can just have a normal diet after 3 weeks and be okay. If you, on the other hand, have osteoporosis, then your diet doesn't have a lot of calcium containing foods, then I would take roughly 1600 milligrams of calcium a day as supplements. Shill Ligley. On hyperplasia, you went over fat. Fat content goes down and as PTH goes up. Is there a test to see if fat went down in parathyroidism? No, there is no test. You would have to take the parathyroid out to see if the proportion of fat, but that's not what you're looking for. You don't care what the proportionality of fats to parathyroid cells are. You care about how much parathyroid hormone is producing and how it's reacting to your calcium. So you don't need that. You need to look at the numbers. Ben Carlson. Hi Ben. Um, so Ben, I believe you're from Sweden and you had two unsuccessful surgeries, and on your scans, if I remember correctly, they found the parathyroid sitting in your upper chest, um, and they're not willing to do a third surgery to remove it. I've seen your scans. I think you can have surgery, but you try to take Sensipar and now you say that my stomach can't handle it, which can happen. So the the only thing left is to either let it be and exist as you are, or find a surgeon who has expertise and is willing to take it out. I don't know what to tell you. I know you keep coming and hoping for something new. Hopefully, a new medication will come out at some point. I don't know even know if it's in the works. Hyperparathyroidism is just not sexy. So, but hopefully it will. All right, my friend, best of luck. Natasha Venus. My calcium has been slightly elevated for close to 10 years now, but never high enough for doctors to be concerned. Once my vitamin D came back low and pH slightly elevated, but ever since then they have been normal. My urine calcium has remained elevated as well. Can these still be indicators of hyperparathyroidism? Yes. So, in a normal parathyroid environment, when your calcium, your parathyroid, so your calcium and parathyroid follow a graph like this, which means that when your calcium is high, your PTH should be low. And when your calcium is low, your PTH should be high, right? So if you have a high normal calcium and a high normal PTH, then you're not on this curve and you have hyperparathyroidism. So you have to look at the trend. If your trend is this and it's gradually going upwards into the abnormal, towards the abnormal, then you have hyperparathyroidism. You just caught it in what the laboratory calls normal. Fay Lewis, ergocalciferol, vitamin D, and cholecalciferol are both forms of vitamin D, but they differ in their origin and structure. Well, Fay is going to educate us. Beautiful. Ergocalciferol is derived from plant sterols, while cholecalciferol is produced in the skin from the steroid precursor. Plant stanols are similar to plant sterols but are saturated, meaning they lack double bonds in their structure. One does not turn into the other, neither do the further metabolic conversion. All right. Okay. Thanks. Thanks, Faye. Emma Hasley, thank you for answering my previous question regarding post-op recovery. Can I ask your opinion on the tablets alendronic acid? I'm 33, 4 weeks post-op and have osteopenia. Diagnosed after a tibia plateau fracture in August due to hyperparathyroidism and high calcium levels. Due to my age, I would rather stay with medications and naturally live. Your bones will regenerate, especially since you are 33. Okay? Do weight-bearing exercises. I guarantee you, in a year and a half, if you do a bone density study, you will have stronger bones. You don't need to take medications. Rachel Robin Provost is asking, is this being recorded so I can listen to everything again? Yes, Robin. It has. That's the end of questions and comments. Thank you everyone for your input. Thank you for asking interesting questions. Hopefully this helps a lot of people, which will make me very happy. Have a wonderful day, week, and month. See you next month.